that more Indians live on reservations and how many people think more Indians live in urban areas? Anybody want to take a guess?
Urban?
Urban? Who said that? Was that Cohen?
That's Cohen.
Was that okay. So that's actually correct. The majority of Indians live in urban areas now. It's about 65-35 right now, give or take, because the census isn't always the most accurate thing. But the reality is most Indians move around. That's that spot in the middle of this Venn diagram. So you might have grown up on the reservation, you might move to the city to go to school, then you might come back to the reservation, or maybe you grew up in the city and you wanted to get more in touch with your culture and heritage, so you move to the reservation, and then you come back, or, you know, wide range of stuff. Maybe you need a job, so you go to the city. Okay. So that's important to keep in mind. And Indian Health Service has a requirement to serve Indians on the reservation, but it doesn't have a requirement to serve Indians in the city, but it does try to. Okay. So these are the top 10 leading causes of death for all races, and all races means everybody combined, Black, white, Indian, Latino, everybody. So if you look at the two biggest ones are heart disease and cancer. And then after that, they kind of all go down. You've got stroke, accidents, chronic lower respiratory disease, Alzheimer's, diabetes, flu or pneumonia, kidney disease, and suicide. So I'm going to show you the Indian ones, and you'll see that they're very similar. You've got heart disease, cancer, diabetes, accidents, chronic lower respiratory disease, stroke, kidney disease, flu, pneumonia, Alzheimer's, and septicemia, which basically is you get an infection and it doesn't go away, so you die from it. Now, if you compare, here's the top 10 from all races on the left and American Indian on the right. You can see we both have heart disease and cancer really high, but then diabetes is the next one in line, which is way down on the list for everybody else, but not for Indians. One other thing to keep in mind is that with these illnesses, American Indians are dying at a much higher rate from them than everybody else. So although heart disease might be the top, more Indians, the Indians die at a higher rate than others. And here's an example. A disparity just means there's a difference. And these disparities are based on American Indians versus the rest of the population. So liver disease, which often is caused by alcoholism, we die 368% more often. That's an awful lot. Diabetes, 177, unintentional injuries, assault and homicide, suicide, and chronic lower respiratory disease, we all die from at a higher rate than the rest of the population. Everybody thinks suicide is really high, and it's true, it's really high, but only for American Indians in the age group of about 12 to 25. I actually raised that up to 30. That's usually where the suicide rate is the highest, much higher than everybody else. If you break it down and you look at, like, let's say 30 to 50-year-olds, then actually white people are higher. They kill themselves at a higher rate than Indians do. Okay. So this slide, I kind of want to point out the difference between the public health and like a regular health. So public health, we look at like a broader population level. So let's say let's talk about diabetes. And if you see the TP, counseling education is probably like, it affects the least amount of people. It's me telling you about diabetes, me giving you a brochure, me lecturing you about how to eat more fresh fruits and vegetables and less, whatever, fats or something, sugars, okay? Clinical interventions are prescriptions, or if we step in and try and help you, like you have really high blood sugar, we're gonna come in and intervene. Immunizations are long-lasting protective interventions. Those are good. They help a wider population, but they're not considered like the best. Infrastructure are things like making sure that people have access to the doctor, or in the case of like diabetes, making sure that wherever the communities people live are, that they have access to fresh fruits and vegetables, even in the middle of winter or whatever. And then socioeconomic factors are what affect the largest portion of the population, and those are things like poverty or education or the fact that people don't get those things depending on where they live. So when we talk about upstream or downstream approaches, you want to make sure that you have the largest impact. And actually this graphic is kind of reversed. The largest impact should be upstream and the small should be downstream. So if we were to have a policy where we vaccinate a bunch of people, that's sort of an upstream approach versus waiting for people to get sick with whooping cough or whatever and treating their whooping cough when they come in with that. And when you're trying to save money, you want to use the approaches that affect the most number of people. So everybody always talks about all the things we do badly at Indian Health Service. And I don't work for Indian Health Service, but we're funded by them partially. So some things that Indian Health Services does really well compared to the rest of the population is that they vaccinate. American Indians have one of the highest vaccination rates of any other group of people. In some communities, it was as high as like 97%, which is very, very good. And as a result, some of our vaccine preventable illnesses have gone way down and actually are much lower than the rest of the population. So things like hepatitis A and B, pertussis, a lot of the baby vaccines that you get. You don't hear about an outbreak of measles in the Indian community because most everybody's been vaccinated for it. But you'll hear about outbreaks of measles, for example, in urban areas or colleges where you have those people who think vaccines cause, I don't remember what they think it causes, autism. It doesn't, but they just think it does. Anyway. We do really good at diabetes care. When people are diabetic, they work really hard to make sure that to have less amputations and things. And we do really well at public health focused care. So one of the things they did in the recent past is vitamin D. So vitamin D is linked to your mental health. A lot of times people with low vitamin D get depressed. While in the middle of winter, when you don't have daylight all the time, most people aren't getting as much sun. Oftentimes we're indoors, so we're not getting as much vitamin D, and as a result, it causes more depression, which then can also cause things like suicide or increase the likelihood. Like if someone was kind of on the border between being suicidal or not, just that little bit of vitamin D can push them over the edge or not. And so they prescribed vitamin D for almost every Indian that they could think of across North America. And as a matter of fact, the vitamin D actually reduced the numbers of suicide dramatically. It also reduced incidences of like depression and things in the community. So that's kind of cool example of how that works. And then we also do a lot of single visit stuff. So Sarah, I'm assuming in Denver, I'll use when you used to live in LA as a better example. When you lived in California, if you want to make an appointment, they're going to have you make a separate appointment to see the doctor. And then if you need some treatment, they're going to make you make a second appointment for that. To get a flu shot, that's another appointment, right? And that's all because when they bill, they can bill you a different amount of money for each of those separate 4 appointments. Well, Indian Health, and it also takes time out of your day to have to come back all the time. So Indian Healthcare, you could go in once, and they'll try and get everything hammered out in one time because it saves them money. So I can go in and get tested for STDs, get my flu shot, get vaccinated for, I forget what that one is, so Gardasil or whatever, I can get that. I can also have my blood sugar checked all at the same time. They're going to try and get all those things hammered out. And they do. They're like, boom, 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 boom. And it saves them money to do it that way.
Isaiah, we're at time. Oh, good. Perfect.
Good.
Time.
That was the end of my presentation. So thank you very much for listening.
Thank you.
I don't know how to unshare my screen now. How do I unshare it?
I think I did it, maybe.
Can
I don't
you take
know.
away my...
You have to say stop sharing.
Okay, I have to find it now. Stop sharing. Oh, there we go. Okay, I see it. Got it. Okay, good. Sorry.
Thank you so much, Isaiah. I think that that was really interesting, and you provided a lot of information, and there's stuff in there I didn't know. So I really appreciate it. Now we are sort of going into Q&A, but before we do that, I wanted to just also mention that the connection between this work is actually really important because sorry, I'm trying to figure out how to share just one screen and I still can't figure it out. But because we have a standing commission on health. And so our standing commission at the Episcopal Church actually does resolutions that go to General Convention on all kinds of health related issues. And Isaiah, you happen to be sitting on the standing commission for health, right?
Sorry, I had it on mute. Yep.
Can you tell us a little bit about, like, off the top of your head of like issues you guys are looking at right now?
Some of them were something about people with disabilities. That wasn't the subcommittee I was on for it. We also were talking about the health status of women across the world, things like women's access to medical care and contraception and things like that. We also talked about something with donating blood, because right now gay people can't donate blood, but trying to get that switched around. And there was another one with insurance and something about the new Obamacare, basically how to help implement that across the country or how to support that, universal health care. And then there was some challenges there between the fact that many of these things are United States focused, but the reality is the Episcopal Church exists around the world. And so how do we do things that sort of help, how do we balance those two things? Like things for the US, like Obamacare, but knowing that that won't affect the people in, where's that country you go to all the time? Where
Ecuador.
Yes, thank you. That won't affect people in Ecuador.
Okay, great. Yeah, I think this is a really great forum and information for everyone to know about the links that if you do see a health issue or know of a health issue or have connections to people, like Caressa used to work at a hospital. So she knows all about health issues. So it's just a good link for you to be aware of an avenue for advocacy. So Isaiah would be one of our avenues for advocacy at the Episcopal Church.
Let me say something about that, though.
Sure,
my term is set. As of this general convention, my term will be up. So it would be great for somebody else to volunteer to go up on there as an American Indian, because I'm the only one right now.
Thanks for sharing that. That's also a really great point, is that we're always trying to get great representation on standing commissions. And usually what happens is around General Convention is that they begin taking nominations. And this year is sort of an interesting year for the Episcopal Church, since we are evaluating everything about structuring. But usually what happens is there are nominations that go out, and you can self-nominate or somebody else can nominate you, and you can say what you're interested in on the form. And then they puts you into a round of pools where they pull people from to represent different communities on these standing commissions. And usually I know that the president of the House of Deputies was very intentional about making sure that we had Native American and Indigenous representation on every possible committee. So just having a really great group of people who can lend their experience and voice to these boards is really, really important, because without it, we don't have anyone there to speak up for us. So I just wanted to also say that. So thank you, Isaiah. And I'm going to hand it over to Cohen for this next portion for Q&A.
All right. Basically, with our Q&A, when you have a question, would you first introduce yourself and give your name, tribal affiliation, where you live and work, and what your focus of ministry is? So opening it up to questions, just remember to introduce yourself first.
Cohen, do you have any questions?
Not off the top of my head. I can introduce myself to give you kind of an idea. I'm Cohen Matoka. I live in Virginia. I'm a Virginia native of the Chickahominy tribe, and I live near DC. I work in research and administration for Indigenous Ministries, and I also am involved with the Indigenous Women's Circle in advocacy. I do have a question for Isaiah about the standing commission that you are on until June. With regards to women's health, are there any particular issues with Native American women's health that you think need to be addressed more?
Absolutely. I think in general, they're talking about women's health in general, but specifically with any women's health, you have issues of domestic violence and sexual assault. Those are probably two of the biggest ones. Another thing that's also coming up a lot more, and it will probably affect some of your parents and possibly yourself, is there is a problem or a large, I don't want to use the word outbreak, but we have a problem with hepatitis C. And the problem is that, one, hepatitis C is not vaccine preventable. And most people who have it, it can be dormant. Like, you might get it when you're between, let's say 14 to 30, when you're doing all your crazy behaviors. A lot of people get it from self-made tattoos, and then you won't find out that you have it until you're, 50 or 60. And it's pretty dire. I mean, if you get it, it's not, in many cases, it's actually worse than HIV, I would say, because the treatment isn't as good.
So what is hepatitis C? Like, what is it? And you kind of mentioned how you get it, but.
Yeah, hepatitis C is a form of hepatitis that is mostly transmitted blood to blood. So sharing injection drugs or needles, sharing tattoo needles. If you Sundance and you pierce and you use the same piercing tools between people, that's another way to get it. It can, anytime, basically most of the ways you get it are the same ways you get HIV. So some rather rough sex, you can get it. Regular sexual contact, probably not, but some you could, especially anal sex, I would say definitely. And so you don't have any symptoms when you first get it because it affects your liver, and it can be dormant for a while. And then once you realize it might be too late because your liver is already in trouble then. So the best way to protect yourself is obviously protecting yourself the same way you would do against HIV. But the two are linked often. There was actually a case where the Veterans Hospital, they were doing colonoscopies and they didn't know how to use their new colonoscopy machine or how to clean it correctly. And they ended up giving it, one person had Hep C and they ended up giving it to 10 other people who got the colonoscopies after that.
Oh my gosh.
Yeah. And so anyway, the treatment for it is interferon, and it's a virus, which are harder to treat than a bacterial infection or something like that.
What about the HIV AIDS rate in Indian country? That's something that you hear a lot about from time to time.
It's, and I don't know across the country. I know in Wisconsin, it's not considered that bad. In other regions, it is worse. I think we are the third highest rate of infection. So the problem is we're such a small population that nobody freaks out until all of us are dead or it's really bad. And so we're the third highest in terms of rate of infection. So that means I think it's black folks, then white folks, then us in terms of who's getting it the quickest. One thing that is really unfortunate is we have the highest rate of diagnosis to death. So from the time we're diagnosed, we are dead sooner than other folks. And that probably has a lot to do with the quality of medical care you can get in rural communities once you're diagnosed. It also probably has a lot to do with folks not getting diagnosed until much later. They don't realize they have it until a bit later. So that's all the more reason why testing for HIV and Hep C should just be a required part of your yearly physical.